Thank you for joining today's webinar. Before we begin, I'd like to cover a couple of logistical issues. If you come across any technical issues, please chat to the host. You can find the chat box on the right side of your screen, and if it doesn't appear, click the dialog bubble on the top right toolbar and it'll pop up. During the webinar, you can chat comments or questions to the panelists. We're going to hold questions until the end of the presentation and then go through them. So thanks for joining us, and let's get started. So on behalf of the Community Technical Assistance Center of New York, it is my pleasure to welcome you to the first of a three-part series entitled Parent-Centered Recovery-Oriented Care, Person-Centered Recovery-Oriented Care in a Managed Care Environment. Are you ready? My name is Jim Rodriguez, and I'll be the moderator of the webinar. So for each part of the webinar series, we have an exceptional group of presenters who all have experience providing person-centered recovery-oriented care, as well as extensive training experience. Today, we'll be kicking things off with part one in the series, Person and Family-Centered Planning and Leadership, Implementing Recovery-Oriented Planning at the Organizational Level. In today's webinar, you will explore ways to transform your organization into one that is person-centered and recovery-oriented. Presenting today are Dr. Edie Schwartz and Ruth Cologne-Wagner. Edie Schwartz has a long history of leadership in the field of mental health, where she worked with programs to infuse recovery into service provision. Dr. Schwartz teaches courses at Lehman College and the Hunter School of Social Work on leadership and leadership and management and recovery-based mental health services and psychiatric rehabilitation, and she's a national and international presenter on these topics as well. Dr. Schwartz has been involved with the New York Association of Psychiatric Rehabilitation Services, NIAPRS, for many years, and in 2010 she joined the NIAPRS team as the Director of Systems Transformation Initiatives and provides technical assistance and training on a variety of issues, including transforming to a recovery-based service system. Ruth Cologne-Wagner has over 26 years of experience in the field of child welfare and mental health care, working with children, adults, and families. And for the last 12 years, Ruth served as a director of various mental health programs in the Hudson River region and has worked to bring recovery-based approaches to the programs she's managed. And currently, Ruth is Senior Projects Coordinator with NIAPRS, where she directs and manages the work of the training collective staff who train providers across New York State in recovery-oriented principles and practices. So with that said, I'd like to turn it over to Dr. Schwartz and Ms. Cologne-Wagner.
Well, Jim, thank you so much. This is Ruth, and we really, really appreciate you having us join you today. This is really exciting to be leading off the very first of your webinar in this three-part series. Thank you. And let's just get started. So when you think about systems transformation, I think one of the first things you really think about is mission, vision, and values. And I'm going to ask you just some questions, and these are not polling questions. These are just questions really to stimulate your thinking. Does your organization have a vision statement? Does your organization have a mission statement, value statement? And you know what? The chances are that you do. The other question is, do you know what they are? And is that vision taking you to where you want to be? These three statements have the real powerful ability to transform a system. And more importantly, when I really think about transforming a system and transforming ourselves as providers, I really think about us passing that transformation down to the people that we work with. So with that in mind, let's review our learning objectives for today. The first is really to understand the model that we all came from. The majority of us learned this in school years back, or in my case, years back. And we're going to compare that to recovery-oriented care. You're also going to begin to envision where you want your organization to go, and you will review the benefits and challenges of the transformation process. You're going to determine your organization's readiness to change, and that will stimulate your thinking on that and provide you with some resources. And we will also describe the interconnectedness between successful participant goals, to successful organizational goals.
So this is Edie, and I will join Ruth in saying thanks so much for having us. Ruth and I are going to pass the ball back and forth today through this presentation, so hopefully you'll get used to our voices and be able to tell us apart as we move along. So, you know, those of you who've been around for a long time, if you look at this chart, it'll be familiar to you. Those of you who are new to the field, take a really good look at this chart, because we have been all over the map in behavioral health care. We have been in such a movement from the 70s to now that, and I've seen quite a bit of this, and it's been really sort of mind-shattering to watch us move from the 70s, when we were all about maintenance and symptom management and people staying in back wards of hospitals and sheltered workshops, through to where we are now in a much more recovery-oriented vein. When I went to social work school in 1980, I graduated, I was told that the best thing you could hope for people with serious behavioral issues was to be maintained in the community outside of the back ward of a hospital, and that was sort of all you could hope for. And haven't we come quite a long way from there? Next slide, Ruth. So this is where we are right now. We are really in 2015 and marching forward to the triple aim: better health care for the population, better care for individuals, and lower costs through improving care and more effective outcomes. That's what you hear all over the place. It might be financially driven, but it's also driven by better outcomes. We're no longer looking at what we do by how many heads we counted who walked in our door. We're looking at how many heads we count who walk out our door with a life back. And the primary trends that we're seeing right now are moving towards person-centered planning and recovery-oriented systems of care, which is why CTAC has put this webinar series together and why so many of you are on it today. We're looking towards integrating care in substance use and physical health and mental health. We are not just separated. We're people who have intricate, interwoven issues to deal with. And we're about wellness, not illness. We're not about symptoms all the time. We're about a well and healthy life. And we're about being a part of the community and being integrated into the community, into a full life. And what are the services we see that are all over the place now that didn't used to exist in the 1970s and 80s? We see DISRIP networks and health homes, and we see integrated clinics and clinics with dual licenses, and we see peer services just blossoming all over the country. And we see care coordination growing instead of case management, which was a great service but wasn't as all-encompassing. And now on the horizon, we see managed care and home and community-based services that will allow us to be reimbursed by Medicaid for the social determinants of health, the things that we need to be healthy: employment, housing, peer supports. And so I'm looking, even though it's a rapid time of chaotic change, I'm looking to where we are and where we're moving to as a very positive force. Ruth?
Thank you, Edie. So in thinking about what you said, Edie, and changing and transforming a system, one of the first things we have to do when you're thinking about recovery-oriented care is really just understand recovery. And before we go to a definition, I'd like to just present to you Dr. Patricia Vegan and a quote that she has here on recovery and our role in a person's life as they're moving towards recovery. And so this is absolutely one of my favorite quotes. She's been quoted many, many times. This is my absolute favorite. Dr. Vegan is a psychologist. She's an advocate, an innovator, a peer leader, and for me, she's an absolute inspiration. So please indulge me while I read this. It is our job to ask people with psychiatric disabilities what it is they want and need in order to grow and then to provide them with good soil in which a new life can secure its roots. And then it is our job to wait patiently, to sit with, to watch with wonder, and to witness with reverence the unfolding of another person's life. And my gosh, every time I see this quote, it really just brings me back in touch with why I went to social work school and why I'm a social worker now. I think she's an absolute inspiration. So this is SAMHSA's working definition of recovery, and as we move deeper into this work, it just really makes sense to start with what is SAMHSA's definition. And you see it here. It's a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And those of you who have been around long enough to remember the traditional models of care, the medical model, may remember that what recovery meant a long, long time ago was really the absence of symptoms. And that's really, thankfully, that you don't see that there in that definition. That is thankfully not anywhere there today. So the other thing that we find is that recovery is a really deeply personal, and it's a unique process. And you're going to find that the people that you work with, they're each going to have their own ideas and their own feelings about what recovery is for them. And although we haven't listed it here in this slide here about basic principles looking through the recovery lens, we haven't listed SAMHSA's 10 fundamental components of recovery. But they really do serve as the foundation for looking through a recovery lens. And there are 10 of them, but some of them are respect, hope, self-direction, and empowerment. So as we look through and we look at this slide and we look through a recovery lens, we know that recovery is possible. Recovery is based on respect. Recovery is highly individualized. And as we were talking earlier, recovery involves more than symptom reduction, and it can even occur even though symptoms may return. So each of us in this field, I tell you, whether you're program line staff, director, support staff, manager, CEO, definitely psychiatrist, maybe even your board and your CFO, we all need to know this. We all need to know what recovery and person-centered work is, but when we also must believe it and actually live it in everything that we do and that we say. And that really brings us to a change of focus in terms of the way we think. And so this really, in a very simple and a very concrete manner, breaks down the traditional focus and a recovery focus. And let's look at how we are changing our focus. So in the traditional focus, it really was focused on symptoms. In a recovery, person-centered focus really looks at a person's uniqueness. The client used to be seen in the context of the system. So what does that mean? How many hospitalizations they had, how long they've been in CDT, how long they've been in PROS, things of that sort. And now in the recovery system, they're really seen in the context of their communities and the lives that they live. Traditionally, we used to emphasize deficits and needs. It was always very uncomfortable to do that for me back when I was taught that. And thankfully, recovery-oriented care came along, and now we emphasize strengths and gifts that people bring. And also what struck me is we all used to think that there was only one expert in the room, and that was the provider, whether it was the psychiatrist or the social worker. And now we realize that there are two experts in the room. And I dare say that the real expert in that room is the person receiving services. So I think that you can probably agree with us that our field really does need to keep striving to attain this change of focus at all levels. Like I said before, the leaders, the managers, the directors. The question we have to ask ourselves is, are we confident that our staff, each of our staff, operate in this recovery-oriented way? And, you know, it's like with everything. Some people do and some people don't. And so I think our real challenge becomes in setting a vision of recovery and transforming our organization and then committing to that.
So we have one poll question on this webinar, and we wanted to take this opportunity as Ruth and Edie have been describing sort of what recovery-oriented care is to ask this question. Before I do, though, I just want to remind everyone, again, some folks joined later, if you have questions or comments for the presenters, you can chat those questions or comments to us, to the panelists. And I'll be accumulating those questions, and then at the Q&A at the end of the presentation, we'll review those with Edie and Ruth. So the poll question that we have is, to what degree do you feel your agency is providing person-centered, recovery-oriented care? And the choices are very high, high, low, or very low. Please indicate your opinion by marking the letter corresponding to your choice. And we'll take a couple of minutes to let it tabulate, or seconds, it doesn't take that.
I hope you've all filled out your poll.
And we do have, actually, it's a bit difficult. And the poll is back, but I actually can't see the percentages that are there. But you can see very high, very low number of people said very high, 11 out of 171 responses. A high degree, 42 out of 171 folks responded high degree, and then 9 indicated up to a low degree, and there were none who said very low. Okay, and then there were a number of folks who didn't answer. But those numbers indicate a need here. Okay, Ruth, Edie, back to you.
Great. Can you remove the poll from my display, please? Great. So we're going to go back to creating a recovery vision. Remember what Ruth started off with? You know, everything begins with a vision. And I think that what's important here for us to know is if we're looking at life, at our work, through that recovery lens, what kind of vision is it that we're looking to establish? And what it is what you have before you. It's a belief system that's down deep inside. And it takes a while to uncover it because most of us were not taught this at school. And so we need to really believe that recovery is possible no matter what for every person. And that means for people who we have traditionally called high functioning and people who we traditionally called low functioning. You know, Patricia Vegan doesn't use those terms. She says people whose gifts are easily seen and people whose gifts are a little bit harder to uncover. And I really like that. But the belief is that everyone can recover no matter what the disabling conditions they're dealing with. And when you do that, you're really helping people to reauthor themselves. By that I mean to look at themselves in a different way and begin to uncover their abandoned hopes and dreams. Because when you go to program and people say they have no goals, part of that is because people don't have hopes and dreams anymore because they have lost them. And so I think that by helping people to uncover those hopes and dreams, you're creating that recovery vision. And in this way, by moving that belief system forward, you're assuring that everyone can get the meaningful life role that they have always wanted and that they deserve to have. So what if you don't have a vision? I mean, some of you are saying, I'm there, I'm with you. We have that. It's written on our wall. We have inspirational messages everywhere. Others of you are saying, I really believe that, but they don't really believe that here, or I'm still under the medical model and we're still deficit-based. What do I do? And so we put up a few things about what a vision statement is. You know, it's a big picture item. It's not a mission statement. It's not an action plan. It's not something that you can achieve tomorrow. It's a large look at what's ahead of you. It's a dream, and it has to inspire enthusiasm and commitment of your staff. It has to be something that's ambitious and that brings people along and that makes you happy to try new things and to kind of change. Change is hard. We're going to get to that a little later, and you want to have a vision to move to, a reason why you should change. So here's some examples of what vision statements are. For every child, life in all its fullness, our prayer for every heart, the will to make it so. A world where everyone has a decent place to live. And for us, in the behavioral health system, look at the last one. Bill Anthony, my mentor from the Center for Psych Rehab in Boston University. We envision a mental health system in which persons with psychiatric disabilities can receive the help they need and want without having to pay the ultimate price, their dignity. Because things have changed, and we've certainly talked about how they've changed, but they haven't changed totally. There still are places, we see it in the media, where people's rights are removed, where every day, even as we speak and have this webinar today about vision and mission and recovery, some 16-year-old is being told to give up their dreams, drop out of school, you'll never marry, you'll never have children. And you know that these things are going on even now. So we can never let up on remembering that everyone has a right to a full life, and our vision statement is what begins to bring us there. The other thing that should never, ever be underestimated is the power of leadership in the development and transformation to a recovery-oriented system of care. I've said a number of times, change is hard, and I'm going to keep saying that. Change is very hard, and knowing that someone is there with you every step of the way is what helps you to change. Think about your clinical work. Compare it to that. Compare it to someone's recovery journey and their willingness to take chances in their recovery journey if they know that a family or friend or worker will be there with them every step of the way, holding their hand and making sure that the choices they make are theirs and that their recovery journey is safe. And so leadership becomes really important here. And through the leadership, we use that vision we've created to inspire not only the people who work in our organization, but the people who come there to do the work of recovery, and to the people who fund us and entrust us with their money. And so leadership is important in every angle. It uses the vision to shape the future. It helps to bring more funding in by persuading others about how potent our vision is and what our vision can end up looking like. These are the things that leadership can push forward. So why should I even bother to do this? I'm happy where I am. It's quiet in my organization. I'm making my revenue. I have plenty of people coming. My productivity is good. Why would I bother now to make this huge shift over to what these two people are telling me is a recovery-oriented service system? Well, those of you who have made this shift already, and I'm sure there are quite a few of you, you see that people actually get better. and they work harder if it's their goal. I mean, think of yourself. Think of how you work when you've helped to create a goal, when it's your business, when it's your idea, when you're moving towards something in your health or your life that's really your thinking. And you've moved it quite a bit, and you work harder for it. Once that happens and somebody meets a goal, all of a sudden they've rediscovered their own dream and their own hope. And that catapults people even more quickly towards recovery. And what that does, it begins immediately to make staff feel better about working with people, and staff retention improves. So the power sharing in making a respectful, even relationship, where, as Ruth said, there's two experts in the room, that reduces the burden on staff tremendously. And it makes people feel like they're really involved in a give and take rather than a lecture. And people like that. So on that end, you know, those are sort of the human clinical reasons to change. On the administrative end, the new Accountable Care Act, not so new anymore, demands that our services be coordinated, active, engaging, accountable, integrated, you've heard this all, and person-centered. And if we don't have them, we will go out of business. And now that we're moving towards managed care more quickly as we speak, managed care wants successful outcomes. They're not that interested that we saw 2,500 people in a year. They want to know what happened to those 2,500 people, and in the long run, did the cost go down, and did folks get more well? And Olmstead, which has really been bringing state by state suits against states for keeping people in more restrictive environments, emphasizes integrated supports and less institutionalized separate services. So what you've got here is you got change from two possible arenas. You've got it internally from it just makes better clinical sense and program sense. It's just a better thing to do, to the fact that externally the world is pushing us in this direction. And for those who have felt it all along, it's just a help that the outside external world is pushing us in this direction. Don't see it as a negative. When I said to you these are exciting but chaotic times, to me they're exciting because they're pushing us towards recovery. Now we must go towards wellness and recovery, and that's a good thing. But I don't want to leave you without talking about the problems. I mean, there are issues. There are always strengths and barriers, and when you just present strengths, that's really not okay. So I did list for you some barriers, and I think that these are the things that you're feeling every day. Before coming to NIAPRS, I was the executive director of a treatment agency in Putnam County and experienced these things really firsthand as we moved that agency to a recovery-oriented system of care. And some of them, you know, they're all real. If you move from a program that bills Medicaid for someone 5 hours a day, 5 days a week, and you move instead to a place where people get jobs and a life and friends, and all of a sudden they're coming 2 days a week for 3 hours a day, your Medicaid money drops drastically, and you have to rework your business model. That means more people coming in, different kinds of work, more paperwork, workforce retraining. If you're thinking about the community and being a part of the community, you have to learn the community you're in. You have to not provide a gym on site. You need to make an arrangement with the local gym, not have a book club on site. Go to the library, make arrangements with the library. These are time consuming, and they're sort of unfunded mandates. You know, they're not paid for. And so there's a lot of change that goes on, barriers that are not insurmountable, but that we need to know about. Person-centered work takes a lot of time. It's one thing to sit down and you have 10 treatment plans to do, and you write them all between 5 and 6 o'clock on a Thursday night. It's another to sit with each of those 10 people and really go over what their hopes and dreams are and what they're going to work on and prioritize what they're going to work on and break it down into manageable steps to how they're going to get there. That takes a lot of time, and our caseloads are only going up while the person-centered work is taking more time. The other piece that some of you may feel, once I was presenting, I asked my staff, what's the hardest part about what we've done here? And what they told me was this bullet, feeling alone with the recovery approach. Because when they were at our agency, everyone was on the same page. But the minute they went outside to discharge planning meetings, to other kinds of places, people were looking at them like they had two heads. They were like, what are you talking about? That's not the kind of thing we do. We don't do that kind of work here. Why are you doing it? So there is much less of that now as more and more of us are shifting our thinking and moving over to recovery. But don't be surprised if you find, as you move into real person-centered work, that other people may not understand where you're going. And it requires a shift in thinking. You know, the first thing everyone says is, I believe in recovery, I believe in person-centered, and of course we do. Who would go into this field if we didn't believe in that? We certainly didn't go into it to become rich. So we went into it because we wanted to make the world a better place. And oftentimes we wanted to make the world a better place than maybe the one we grew up in. And so those feelings, that vision, that inspiration, those values are the things that have moved us into this field. And the thinking on how to help people get that is shaped often from those that slide I showed you about the 70s, 80s, and 90s and what we learned in school. And so there's a shift in thinking for us, and there's also a shift in thinking for participants who have learned through the years, through the system, how to be, in quotes, a good patient, which is just do what you're told, raise your hand, and don't have a lot of hopes and dreams that might get dashed. So developing and sharing those hopes and dreams and helping people to change the way they think, that's what gets you to your vision and your mission. And that is a very hard job. It is not insurmountable, it's not impossible, but it's not easy. And I want to lay on the table that there are many, many people doing this, and you're not alone with it. And I always say when we go in and do transformation training, make sure you have some buddies who are doing this with you. And including participants in all aspects of service planning will help you to get those buddies. Because together, we're much stronger than we are individually. Now you see my old 60s stuff coming out. I can't help myself. So how do I know if my program's ready to change? This in front of you is adapted from a Boston University Center for Psychiatric Rehabilitation Readiness Assessment. And any of you who ever worked in an IPRT or were around years ago when we implemented these in clinics will understand it. I'm just going to take a minute to go over it. And if you want more info on it, you can certainly read about it at the Center for Psych Rehab. And this is about how you assess somebody's readiness for change. And one of there's sort of 5 ways you do that. One is there has to be some dissatisfaction or need for change. And I talked about that before. Either somewhere deep inside you, you have to want to do something different, or somebody outside is really pressuring you to make that change. And I think we talked about that with the ACA and Olmstead versus this is just the right clinical work to do. That's not enough. The next one, commitment, is that in order to really change, now think about this yourself. Think about a time that you were in a program that you wanted to do something new and innovative, and you just didn't know if, number one, that change would be at all helpful, whether you could ever pull this off, and whether in the long run your supervisors would support you in the ongoing commitment to this change. That's really what this is about. Not only do you have to be dissatisfied, you have to actually believe that this is going to mean something and that someone's going to be there to support you with it. And then those other 2 are the awareness of your own value system, who you are, what's important to you. Do I really believe in recovery for every single person? You know, recently I've been doing some work on expanding peer services nationally with a SAMHSA project, expanding employment, expanding peer services, and what I'm always saying is that isn't going to happen if you don't truly believe inside of you that these are services that promote recovery and that people really can recover. So that's what self-awareness is about. And environmental awareness is, let's not reinvent the wheel. Is there someone out there that's doing this? There are tons of people doing this. And let's look at their outcomes. Let's see where they are. Let's see how other people have done this. And the last one is the leadership piece. You know, who is going to be there to help lead the way? So, all right, we just did this whole readiness assessment. Let's say you're not ready. Does that mean you have to throw in the towel? No. There are actually ways, and there's a little link for you down below later on at the end, that you can help to increase dissatisfaction, to increase the belief that that change is positive, to expand your horizons, develop alternatives, to find a leader, and to adopt the vision. And there are mechanisms to actually do that. And in an hour webinar, I can't go through them, but you definitely can read about them. It's an intervention technology, just like any other clinical technology. So I am going to pass the ball over to Ruth now, who's going to continue.
Thank you so much, Edie. So now that Edie has helped us think of visions and a path of transforming our organization, let's actually go into the program level and just let's review very quickly what a program should look like and what it shouldn't look like. And so essentially this slide is what it should do. It should focus on the individual's life goals and needs. And that piece right there, focus on the individual's life goals, that's where you get the person-centered care coming from. It's no longer a goal created by a clinician, like Edie said, at 6 o'clock in the evening without the person being there. This is something that's done together so that it's absolutely integrated and it's something coming from the person, from the participant. Second is maximize choice, and this is just really interesting because some of us work with people who have been in the system for a very long time, and these people are just used to other people making decision after decision after decision for them. And so now here we are saying you've got a choice. And so some people just don't understand that. So we really see it as our responsibility to not only tell them that they have choice, but help them to see that and help them along the way so that they can integrate that. The other thing is to be flexible. And so I've heard of organizations, programs, where they've had to create procedures based on people missing appointments. And then the first one that comes to mind is the 3 strikes you're out. I don't know if you've heard that one, but essentially a person missing 3 sessions, and so there's a hard and fast rule about if you miss 3 sessions and then you're no longer in the program and you're discharged. And so what a person-centered approach would do with that is do just that, do a person-centered approach, and instead of a cookie-cutter response. It's also beneficial for us to know what's our role in helping to engage the people that we work with. And so I actually suggest for you all, when you have time, to go back to the CTAC website, and in there they had a project called the Adult Engagement Dissemination Project. And there's wonderful webinars on how to successfully engage participants. And now let's go to what a recovery program approach does not do. So, no, it does not, it disregards personal values, desires, wishes. No, that's absolutely something I know we all know we should not be doing. Set goals that are unmindful of the individual strengths and limitations. And so this whole list really are no-brainers. There are no surprises here. I think the challenge for leadership is really for everyone to be clear about the vision and everyone, like Edie was saying, to live it and to breathe it. So when we do that, our work is then guided by the recovery vision. So when we're looking through that recovery lens that we talked about, people will improve, they will feel respected, valued, and trusted, and they will design what recovery means to them. And so when that happens, when that happens, people get better, they achieve their goals, they're healthier, and they're happier. And then they move on from treatment. They move on from us in order to be out there and to live their life. And essentially that's why we're here, to watch with wonder, with the unfolding of another person's life. And again, that's Pat Vegan's quote. So of course, when participants are doing well, ER visits get reduced, inpatient stays get reduced length of stays at your program get reduced, positive discharges increase, and so you, the organization, actually becomes more successful and attractive to the community, and as Edie said, to managed care organizations as well. So I know this is a bit complicated here, but let's start with the red arrow and go clockwise. And so when you really think about stimulating wide range organizational change, you do have to create a strategy that supports your vision. And so the implementation plan can be very simple, or it could be as detailed as you need it, but really the basic structure is the same. And so you, the leader, you have the ability to influence others, as Edie was saying, follow the leader. You help them want to act and want to become part of something larger. This really is that vision. How are we going to change the world? How are we going to be part of something larger than ourselves? The implementation plan actually begins with you. What do you personally and passionately want to do with your organization? And then who else is aligned with you? Who shares those same visions, and how can they help create this implementation plan? Create an implementation team, and they'll all help support to move the vision forward. And then, of course, action planning. That's when you really think about what your services are and what your vision is, and to ensure that your services really do promote your vision. And you only support the things that promote your vision. And then in order to know how well you're doing, you first need to understand what it is that you want to accomplish. So you take your vision and that end result, and then you'll have something to measure against, so that you'll see whether you're being successful, not successful, or if you need to change your plan. And that comes up next in terms of flexibility, in order for you to redirect your course based on your findings. And then, of course, probably what I think is just the most difficult is that last one, and I actually put a purple star next to resilience. And it's probably just as difficult as transforming an organization, is really keeping it transformed. And frankly, everyone then becomes accountable to making sure that the vision is implemented and that it stays implemented. So the leader obviously is responsible for this, but now the entire organization has a sense of responsibility not to go off course.
So I guess this is me, and as I do, I guess, clean up, as we wrap up towards the end of our presentation, I'm going to be very concrete, because if there's anyone out there who knows me, you know I love to be inspirational. I love to inspire. I love change. I love to move my furniture around. I love to change offices, and I love to change organizations. But I also like to guide, and I think you can't guide if you're not concrete. So I'm going to give you in the next 2 slides some very concrete things. You've said, okay, I bought you hook, line, and sinker. What do I do next? These are the things that one needs to do. And these slides will be available. So, you could take a look at them and see where you are on this, assess where you are on these scales. But the first thing is establish core recovery principles and values. the ones that Ruth went over. That's why we spent the time going over them. Establish them with all of your staff, from the CEO, CFO, all of your quality assurance people, all the way through, and the people who come into your organization. Adopt a clear recovery-based mission statement. It's not about what you do, it's about why you do it. It's not about I provide 2,500 units of service, it's I am here for the people of this county so that they can have a wonderful life. What is it you do that's special? Why do you do it? What does it add back to society? Post that mission statement everywhere. Post those values everywhere. Live by those values. Raise up the leadership and voice of peers and participants and people in recovery, and assure that they are a part of this planning and policy development at every level. And there may be limitations, as I pointed out, and barriers. Go past them. Find other ways. If for some reason in your organization you can't get peers on your board, get consumer advisory groups that feed back to the board. Make sure that you have the voice of people in recovery throughout. Don't expect staff to just jump on board because you're a visionary. Train people. First, get people on board with that vision, and then train them in the actual tools. Remember, I told you that psychiatric rehabilitation assessment, there were actual tools? There are. And there are tools of self-direction, self-determination, person-centered treatment, person-centered planning. These are all tools that you need to help your staff to get. And then create mechanisms to get perspectives from different stakeholders while you're crafting this vision. Don't be isolated within your own organization. Remember, you're a part of the community. Be a part of the community and get lots of people on board to talk about this. Identify your priorities. Be really clear about them to everybody. Make sure that you put your money where your mouth is and only support those services that are consistent with your mission. You know, those of you who are CEOs will feel my pain. We try so hard to keep our organizations alive that we sometimes follow the money instead of the mission. And now that we're moving towards managed care, one of the things I've been talking to people a lot about is how do I keep the integrity of my recovery services and be managed care ready? And it's not impossible to do them both, but it's not easy. So again, support only services consistent with that mission. Make sure your policies support everything. About 4 or 5 years after our agency changed, I went through our policy manual and I was appalled at the wording, at the policies. We still had policies like the ones that Ruth was talking about tossing people out, when I'm running around talking about not throwing people out of service. And so make sure your policies and procedures are really recovery-oriented, that your job descriptions are really about the kind of people that you want on your staff, that your performance evaluations demonstrate that, all of those kinds of things, because that paperwork sneaks up on you, and you don't even realize that it's not following where you've moved to. Make sure that you're really about the back door, not the front door. Yes, it's important who comes in. We know that because we'll go out of business if we don't have enough people coming. But look at who's going out. Make sure that people are leaving you and that they're having a quality of life when they leave. And data, data, data. Start collecting it. Start proving that you're making a difference in people's life. And you can't do this alone. You have to have a team. You have to have more than a buddy. You have to have teams. One of the ways we begin transformational changes like this is to begin to develop committees, lots of them, that work on different things. One to work on mission, vision, policies and procedures, different integration of programs, and make sure you include everyone, not just management staff, but participants and direct staff and people from the community who have something to say. And so with that, I'm going to begin to wrap up with just a few thoughts. Change is hard. There are those of us who like change and those of us who don't like change. There are people like me who never have the same seat at the table and love to sit anywhere I go, and people like my husband who, if you sit in his side of the sofa, he can barely contain himself. You know, change is just something. Some of us like it, some of us don't, but even if we like it, it's hard. And look at this quote, it's true. It really gets us somewhere. You know, I hate to fly. I really do, and I go through all kinds of machinations when I get on an airplane. But I fly a lot because I love to travel, and I love to get to where I need to go. And so I live through it to get there. And remember about the destination. I always tell people, remember about the brass ring. The brass ring is watching someone who was in our program for 15 years walk out the door and get a life. And he did. And he lives quite lovely now with a job and an apartment and a partner after many, many years of being a chronic psychiatric patient. No one needs to be that. That's the beautiful destination. And how are we going to get there? You get there first with your mind, and then your body follows. And so make sure you adopt that vision, that you pull that vision together. That vision is incredibly important. It does not beget false promises, but a passion for what we're doing. Don't hide your passion. Your passion is what motivates you and everyone who's around you. Our passion is what motivates those who even come to us for services. Steve Jobs, a very visionary, passionate man, talks about vision and how it gets a life of its own. If you're working on something exciting that you really care about, you don't have to be pushed. The vision pulls you. And I think many of us have felt that many times in our life. And I think if we begin to let go of the fear a little, jump into the vision, jump into what we really want out of life, what we believe in, then the possibilities are limitless. I think with that, we have left you a few resources which you can pull up after. And I think on behalf of Ruth and I, thank you so much for listening to us today. It was a pleasure to speak with you and to share with you our passion and our belief. And I'll turn it back over to Jim for some questions.
Okay, and we do have a couple of questions. Please continue to set them in. A couple of folks sent in questions as we're going on. So the first one is from Daniel Johansson. So the question is, with home and community-based services being funded by Medicaid, how do you deal with the issue of justifying medical necessity, which traditionally has been about identifying needs and deficits, and move to a strength-based, self-directed model?
So that really is one of those barriers that I was talking about. Now, for one thing, home and community-based services, thank goodness, is funded under the rehab section of our waiver. So there are definitions of those services. And as long as you meet that definition, and McTack is doing a great job of presenting webinars for you about what each of those HCBS services are. And then I think there's been 4 or 5 of them already that are probably posted, and then there's more coming. So make sure that you go on the site and sign up for the cluster webinar series on HCBS. For other work, for other person-centered work, it really is about how you state it. And it's really about what is the long-term outcome. So if you're saying that someone wants to get a job, and how can I treat them in my clinic what they want as a job, but what's getting in the way of getting the job? That's where the person-centered work goes, that our next couple of webinars will be addressing. Is it their anxiety? Is it their depression? Is it their difficulty socializing with other people? So you have to get at the medical basis for what's causing the issue that's getting in the way of their rehabilitation goal. Excuse me.
Great. One other question, and it goes to the issue of data that you talked about, Edie. How does one collect data on recovery? One of our participants needs help on this.
Well, there are a number of recovery scales. So if you Google, you know, recovery scales, you will probably find some of them. But I wonder if we can get that person some afterwards, Jim, because I have a listing.
Yeah.
But the other piece besides the recovery scales is that you could simply begin to develop. I mean, they're not valid and reliable, and so you guys at NYU don't listen to me, but you could just develop some outcomes that are important to you. How many people got work? How many people, you know, were reunited with family? How many people, you know, went back to school? How many people, you know, got into stable housing? How many people took back over their finances? You know, look at the things that people accomplish in order to reach their life goals. Begin to separate them out and count them. And that is the easiest way without getting all complex.
Well, great. And actually, okay, great. And actually, so I just want to say that somebody just requested to please include recovery scales in the website or send to all. And that's actually a great segue to end because, so we're going to end the webinar. This brings us to an end. And I want to remind you that there are two more parts to this webinar. So again, this first piece was looking at organizational transformation and what you need to do at the top. As we move into the next two in the series, the next one in the series will be the hallmarks. It's part two, hallmarks of person-centered practices and service planning in managed care environment. So in that one, you should get more information about those kinds of things. How do you document? How do you connect it to managed care and Medicaid and collect data? And in fact, if you have other requests, I can pass it along to the presenters of that one to sort of make sure that they try to address those kinds of issues. So in that webinar will be presented by Valerie Way of East House, a large rehabilitation agency, and Michael Dorr of NIAPRIS also. And that one is scheduled for Wednesday, August 26th from 12 to 1. So if you haven't registered for that, please do so. The third part in the series is going to focus on a very important component to person-centered recovery-oriented care, and that is peer services and peer support. And so that webinar will focus on ways in which peer support providers can maintain the integrity of the services while effectively partnering with other providers. And that one will be presented by Chaku Matai with the SAR Center at NAMI. And that's going to be scheduled, or that is scheduled for September 23rd from 12 to 1. I'm also sending, so if you have requests, as one of our participants did just now, for more information or resources or tools, please send them along to, and I sent it just now to, you could send it to ctac.info@nyu.edu, and we'll try to pass that along to the presenters in the next two parts of the series to try to include in their presentations. And then also you can access the website for the Person-Centered Care webinar series at www.ctacny.com. And we'll try to load up those additional resources and tools onto there. So once again, I want to thank you all for participating. I want to thank Dr. Schwartz and Ruth Cologne-Wagner for presenting. And we will see you in a month.
Our pleasure. Thanks, Jim.
Thank you.
Thank you. Bye-bye.